to the facetectomy and sometimes to the facetectomy of the upper facet. But this is really severe case, more than 100 degrees at, and more than 18 years old. So in these cases, I can do some rib resection from the concave side. And very often we don't need to do gibectomy in these cases. So costoplasty from the convex side.
Thank you. Thank you. Is there any question?
Okay.
I have one single question for you, Ibrahim, about the, I know that you are fond of freehand technique in this kind of surgery, and with the navigation supports now, and you know that in Tunisia we don't have any kind of this support. So do you always deal with this technique even in very severe deformity cases, or you count on other devices? And the other question is, you have talked about the place of the anterior approaches. Is there any indication in your mind about anterior? I know that in the assistants there are some schools who are always on the anterior in several cases. So what are your opinion about that?
Okay. Thank you for your question, my friend. So for the first question about navigation, actually I use very rarely navigation in AIS. I use freehand technique in all cases. I think planning is the most important thing and not the navigation. Very often, even if we have these plastic pedicles, we should know this before the surgery, and if we know that, we can manage the situation without navigation. And another thing is, we are not obliged to put screws everywhere. So don't forget that we have another implants that we can use. So this is also another message that you saw the patient. Actually, you saw one case I used navigation, and the other one I put band, sublaminar band and hooks. So we can use both of them. And actually, I am working in 2 hospitals, and one of them I don't have navigation. And in this hospital, I am doing the most of my deformity cases, so without navigation. So, and even in the other hospital where I have navigation, and I use it only for very severe revision cases when there's no landmark. So it's really, in my opinion, this is the indication. And some other one, like neurofibromatosis, when we have very dysplastic vertebra with the very large dura, ectatic dura. So it's very specific. So I don't use it for AIS. For adolescent idiopathic scoliosis, I almost never use navigation. So this is, you can do all your scoliosis without navigation, I'm sure of that. So this is not the problem. Just, I do very often a pre-operative CT scan. Perhaps it's too much radiation, but for me it's a very, very secure way to plan my surgery. So I do a CT scan limited to the part I want to instrument for all the patient I operate. So I don't, I do the CT scan before surgery. Concerning the anterior approach, it's good to know how to do the anterior approach, because I have the chance to do that in Lebanon, so in the 90s when I start my residency. But now I know that many surgeons just know how to do olive, so they do small incision and they put cage, but they don't know how to do thoracophrenolombotomy or large lombotomy to have the correction from the anterior approach, unfortunately. So now there's very few indications. One of them is severe curves, when we can do anterior release and posterior correction. This is the first one. But I have few indication on that, because I manage mainly that from posterior approach. Second one is anterior tethering for the lumbar curve. I don't do this kind of surgery. Third one is the anterior correction with the anterior column ACR, anterior column reconstruction. It's mainly adult, mainly an adult. For me, I kept only one indication in the AIS is in lumbar curve associated to ischic spondy. So when we have ischic spondy or ischic fracture associated to lumbar curve, if we fix by the posterior approach the lumbar curve, we may decompensate the spondy. So I would do anterior approach for the lumbar curve and posterior reconstruction for the ischic fracture. So this is a rare case, but I had to do this 3 times recently in the last 10 years when I stopped to do anterior for lumbar orthotoracic lumbar curve. Before 2010, I was doing all the lumbar and thoracolumbar curve by anterior approach. So it completely changed.
Thank you. We will debate on that after. Now we go forward for the second lecture, and we invite our friend Dr. Ala Azmi from Palestine, which is one of the most famous surgeons now worldwide in the field of early onset scoliosis. So we know it's not a very common situation, but it causes some discussions. So we are very glad to receive you.
Thank you very much. I'm very glad to be here, and thank you for the Tunisian Orthopedic Society inviting me here. And personally يعني كفلسطيني أنا سعيد إني أكون موجود في تونس. تونس لها محبة خاصة عنا. So I'll talk about early onset scoliosis, advanced surgical techniques. So early onset scoliosis is a complex pathology that covers a lot of etiologies like idiopathic, neuromuscular, syndromic, congenital, with onset before 10 years of age. This is the SRS definition of early onset scoliosis. Now they are talking about less than 9 years of age. There is some controversy about that. But whatever the etiology is, and the child will have a deformity in the spine, it will be called early onset scoliosis. And it's not just scoliosis. Even if you have, yes, that's great. Even if you have kyphosis, it's called early onset scoliosis. What we have learned in the last 2 decades, actually early onset scoliosis was not a popular technique to be done previously, but in the last decades it's booming. A lot of issues are done accordingly. So early onset scoliosis is not a spine problem, it mainly affects the lung. This is a very important issue that we should acknowledge. When we do non-fusion techniques, it's not because of the shortness of the child, it's because we need to expand the lung. And if we know that the lung growth until the age of 8 is through alveolar multiplication, anything that would happen that would restrict the trunk from growing, it will restrict the trunk from growing, it will restrict the lung from growing until the age of 8. So you try to expand the trunk, you try to get the growth of the spine. Previously we thought that just a fusion of the spine is a fusion of the spine. Fusion of the spine is a closure of the trunk. So this is a very important issue to acknowledge. Avoid fusion with evolution of non-fusion options, accordingly of course, and still there is up to now no consensus about the efficiency of any of the approved surgical methods. Casting is becoming more and more popular nowadays in early onset scoliosis. In the beginning, 30 years ago, everybody was doing casting. Then the non-fusion techniques came. Everybody forgot about casting. Then the casting is coming on because of something, is that we realize that as long as you can buy time to get the surgery done for the child in older age, I mean, for example, 5 years instead of 3 or 7 years instead of 5, it's much better for the child. And also because there is no consensus about any surgical management. And early onset scoliosis is a very important procedure. For infantile idiopathic scoliosis, it is therapeutic. So if you have a child that is less than 18 months of age and having a cup angle less than 60 degrees, you can treat